Today, my topic is for placement of reference electrode in motor nerve conduction study of ulnar nerve, especially on FDI, because it is very contradicting, what you call contradicting point, where few different people are talk about this one, and there's a book in some few books as well. They mention about that one. So I will discuss everything in this topic, this presentation. Okay. So according to the Wikipedia, the definition is that a reference electrode is an electrode which has a stable and well-known electrode potential. In the history, if you can look at the history, in the old age, you can see that this tube type electrode, they've used it with that with gradually, if it is warm enough, then it will be die up, and then we have to give a time to be to cool down, and then it will start working. So they normally call them G1, G2, or E1, E2, and the ground or earth as a G. Like this one is normally used for the ground. So these are the historical electrode position. This is the ground. Normally, ground supposed to be placed between the recording electrode and stimulating electrode at the middle. So, and the reference electrode normally put them at the tendon of the muscle. There are few research paper talk about the technical and effect of reference electrode and compound muscle action potential of G1 and G2, E1, E2, or G1, G2. Basically, E2 is the reference electrode, E1 is the active electrode. But everyone has a different idea. So I thought maybe I can do some more research. And I found I look at the history, the term ground was used as for earth electrode, which is very confusing. Earth, the ground is electrodiagnostically recording prefer as a point on the amplifier circuit that is used to be as a point of reference or the voltage measurement, which is very unusual. And the reference electrode is presumed to be electrically silent, but does not record large volume conducted potential, which is again very interesting because in electrophysiological, it is not fit. So when I look at it, the research papers and the books, they have mentioned in different areas of the placement of the reference electrode while recording the FDI, nerve conduction, nerve conduction. They put them at the belly of the tendon, like I saw in the previous picture, which is most of them as a standard normally they are doing. In 1985, Olney or Wellborn noticed that placement of active electrode over the motor point usually did not give the large amount of the response. So they have changed it to different areas. And like in 1991, Dumitru and King demonstrate that the monophasic potential is produced at both a muscle origin and its insertional hand as well. In the 1993, King said, compare the compound emotional action potential obtained with the traditional belly tendon montage with the response recorded over the either at the muscle or at the tendon with the reference electrode on the contralateral side, which is very interesting because contralateral side is far away, means other hand basically they are talking about. So it is very different area completely. So they are very unusual information there in the book. It will be placement. So I thought, okay, I will do some research on it. So I place the reference electrode in different places during the electrode recording the ulnar nerve response from FDI muscle. So these are all of them in different places, which I will explain you in a minute. So when I put them into tendon to belly, this is called normally belly to tendon. This is that belly, and this is the tendon of that FDI muscle. where the response, you can see this one, there's a hump there. If you can see that one, there's a hump, a small hump there. So there's basically, that is called positive deflection, and it is quite difficult to find where actually that the response started. So it is quite difficult, and it's slightly movement of the latency. It will be either normal or sometimes it will be abnormal. So it is difficult for that one. Although the amplitude shows here 13.3 millivolt, when I change the position to which is the different book has been mentioned about that one, that you have to place the reference electrode over the thumb. So which by recording from the belly, this is showing, although there is no positive deflection, but the amplitude is slightly dropped. You can see that was 13.3, now it is 12. Some other people, other research, they put them electrode over the wrist while recording from the same point. The response is again, but you can see that the baseline is not very clear, and it is quite difficult to find that actual point where it is starting. Although the amplitude is 13.4, which is better than the belly one as well. Then another book which talk about that the reference electrode has to be placed over the tendon of ADM. ADM, which is the same nerve, median nerve is supplied, ulnar nerve supplies to both of the muscle. So if you can put that and stimulation reference electrode at the belly, or at the tendon of the ADM, and record from the FDI, the response is very clearly that there was no hump, no baseline problem, and the amplitude is maximum. It is 14.5, which is very big one. So then I tried, just for this for the joke, I did the reference electrode placing at my this is me myself. I put them onto my face to see that whether reference electrode is quiet or not, which is supposed to be, reference electrode supposed to be silent. So when I place them, I can see that one, there is a response as well, although that is a small response, but I can get the response. It means that the reference electrode is not silent. One thing has been proved. Then I place the electrode while looking at the distance between the recording stimulating electrode, because there are different type of stimulation equipment is coming up on the market, that the distance is different from 2 centimeter to 5 centimeter as well. So in this one, I put them the distance latency, which is 2.76, and the amplitude is 13.3, with by recording that because there's a deflection at this point with this one at the base for the positive deflection. So then I changed that by keeping the same reference electrode, placing recording electrode, and just to change in the distance to 5 centimeter. So latency is still 2.6, which is 2.7 to 2.6, which is better, but the amplitude is 13.3 and 13.3. So the amplitude is also same. So there is no difference. So it is also proof that if the distance of the stimulating electrode, if it is bigger than 2 centimeter or 5 centimeter, it will not making any difference while recording the response from ulnar or from FDI. So these are the just giving you glimpses of the books where I found that one. This is the book Manual of Nerve Conduction Study, 2nd edition. It was written by Ralph. You can see that one, that which this is giving a maximum amplitude in this one, that I put the belly active electrode and reference electrode at the tendon of the ADM. This is another book which is Nerve Conduction Study of Surface Anatomy for Needle Electromyography, written by Hang, where he put the active reference electrode at the thumb and recording from FDI. which is showing amplitude-wise, amplitude-wise slightly low amplitude, but on with the baseline was not correct as well. There's another book. It's called Electroneurophysiological Volume 3, Revised and Enlarged Edition, and which is covered that pictures as well. They place the electrode at the reference of the tendon and is belly of the recording placement. And in this one as well, that amplitude is fine, but with the positive deflection was there. And when we, because in England we have to follow for the neurophysiological process by ANS and BSCN guideline. ANS is Association for Neurophysiological Sciences, and BSCN is British Society of Clinical Neurophysiological Sciences. These are the two association here who are looking at it. So in their guidelines, which was published in 2007 and 2014, where it was mentioned the guideline is motor nerve conduction in the ulnar nerve is performed in the affective limb using the surface electrode and measuring the response amplitude and latency conduction velocity. Just a very layman language. There is no clearly guideline where have to place which motor nerve, means which muscle we have to be tested in this one. And then standard, if you can look at it also, a test of ulnar motor nerve conduction in the affected hand is performed using surface electrode and measuring the response amplitude and latency velocity. Stimulation point must include just proximal to the wrist and proximal and distal to the elbow. Again, they are not clearly identifying whether it is we have to record the FDI or ADM from FDI or ADM, because as you know, yesterday I presented my presentation where it was clearly identified that FDI is more sensitive in early recording in early stages, which is not possible for while recording from ADM. So I collected the data of 23 patients, which is normal patient, in different stages, and by placing the electrode. So the total right hand was 20. Sorry, that was 23 patients. So right hand and 23, and left hand 23. So total is 26, 46 hand, but which is 23 patient. So when the minimum latency amplitude over the basement of digit 2, which is 1.5, that is the distal latency, distal amplitude. But maximum amplitude, I found that one is in digit 2, which is 11, and mean amplitude over that one is which is 8.6 coming up. And then if I will move that electrode to which digit 2 is basically the tendon of that FDI muscle. This is digit 2, and then the thumb, which is at the which is the angle, making angle. So if you can see my hand, you can see that one. It will be at the thumb here. So in the thumb, the minimum amplitude was which is 5.2, and the maximum amplitude I found it at 10, and the mean amplitude was 7.9, which is again, as I mentioned, it is low. In this one as well, it is low in the initial activity. Then I moved that electrode to digit 5, in this one, where that amplitude of that one from the base to is 1.5, which is almost the same, but the maximum amplitude is from the base to 5 is 15, which is very nice amplitude, which is none of them has been reached to that one, and the average of that one is 12.35. Then FDI at the forearm, which is again 5.2, 10, and 7.9, and the radial side, which is sorry, other hand, sorry, I did this one is a contralateral hand, which one of that, uh, information which I gave it to you earlier, that the research paper says that we have to put the reference electrode in contralateral hand, other hand basically. So this is showing that one, which is also same as the thumb one. And then when placing the electrode at the radial, which is at the wrist, which is showing the 10.9 maximum amplitude, and the average is 8.55. So maximum good amplitude we can see in that one where we put the electrode in digit 5. Now compared with the latency wise, in digit 2, minimum latency was 2.3 and maximum was 3.2, which is good. And then at the thumb, 2.1 and 3.1, which is almost, you can see that one, all of them are not goes above 4.5. So which is showing that there will be no latency difference, but the amplitude wise there is a good difference, latency difference. You saw that one. So my suggestion is that placement of reference electrode in FDI at the base of the digit 5 would be considered to record the maximum amplitude. 4.5 digital motor latency would be considered as a normal value for FDI, and 4 millisecond for ADM. Greater than 4.5 digital motor latency in FDI and greater than 4 digital latency in ADM could consider as the motor Gaines canal, which I mentioned in my previous yesterday's presentation. Amplitude wise, 5 microvolt and more amplitude could be considered as a normal, which is at present, although they are not mentioning in the guidelines of ANS on BSN, but normally people are taking this 5 microvolt as a normal amplitude of all of them, ulnar nerve, median nerve as well. But dorsal ulnar cutaneous nerve, very less people are doing this one. So that's the recommendation is preference of the, as you mentioned last time I mentioned about this, that FDI is more or I can say shows the early changes. So my preference is that FDI recording would be considered as a routine test instead of ADM, which is at present people are following that. To record an early sign of entrapment in ulnar nerve, this is the reason of that one FDI. If FDI shows any abnormality, ADM should be recorded to confirm that whether it is what sort of the changes are. Reference electrode placement in FDI at the base of the digit 5, which will be considered because which shows that maximum amplitude. And one more thing I noticed that one, that normally it was recommended that when you are doing across the elbow, you should have to be considered to keep them 90 degree of your angle. But when we are doing, when I did that FDI with the digit 5 reference electrode, I tried with the different area, like keeping hands straight and at the elbow, which doesn't make any difference at all in the amplitude wise, and it will be correct amplitude was showing. So I think so that will be a good place. Record from across elbow would be considered as a routine test. If there is a low amplitude, less than 5 microvolt from ulnar sensory from digit 5, recording should be made between mid palm to wrist, which I discussed in my previous yesterday's presentation. If there is a low amplitude between 5 to wrist and mid palm to wrist, dorsal ulnar cutaneous nerve should be recorded to identify whether patient having a Gaines canal or not. If there is a slow conduction velocity between 5 to wrist, mid palm to wrist, and the dorsal ulnar cutaneous nerve, that could be across the elbow, that would be a superficial nerve, ulnar nerve, which is very, I think so, only one research talk about this superficial nerve, but with that very not very clear information.